Hello everyone. In this lesson, let's study post-streptococcal glomerulonephritis. Acute post-streptococcal glomerulonephritis may occur after infection with nephrogenic strains of group A beta hemolytic streptococci. The disease is most common after episodes of pharyngitis. Post-streptococcal glomerulonephritis is an acute immune complex disease characterized by the formation of antibodies against streptococci with the localization of immune complexes and complement in the kidney. We should master the clinical manifestations. More than 95% of patients with post-streptococcal glomerulonephritis secondary to pharyngitis and 85% persons with streptococcal skin infections have positive antibody titers. Most cases manifest with hematuria, proteinuria, hypertension, acute kidney injury, and nephrotic syndrome 7 days to several weeks after a streptococcal infection. A variety of antibodies, such as anti-streptolysin O and a streptozin panel of antibodies against streptococcal antigens, often show high titers. But a change in titer over time is more indicative of a recent streptococcal infection. The serum total hemolytic complement levels and C3 levels are decreased in more than 90% of persons during the episode of acute glomerulonephritis. Pathology. On light microscopy, glomeruli are markedly enlarged and often fill Bowman space with infiltration of monocytes and polymorph nuclear cells, and a proliferation of the glomerular cell elements. The capillary lumens are often compressed. On immunofluorescence microscopy, there is coarse granular deposition of IgG, IgM, and complement, especially C3 along the capillary wall. Electron microscopy shows large dome-shaped, electron-dense subepithelial deposits resembling the humps of camel at isolated intervals along the GBM. The therapy is directed on controlling the hypertension and fluid retention with antihypertensive agents and diuretics. In most patients, there is a self-limited disease with recovery of renal function and disappearance of hypertension in several weeks. However, the presence of underlying renal disease, especially diabetic nephropathy, is associated with a worse prognosis. Let's look at the case finally. 14-year-old male high school student with a history of pharyngitis 2 weeks ago, acute onset, manifest with prominent hematuria and red blood cell clusters. His examinations show abnormal renal function, low C3, blood sedimentation, and anti-tryptophan O increased. What's his diagnosis? How to treat his disease? You can answer the question by yourself. That's all. Thank you.